So imagine this, a patient with a severe burn rolls through the doors. What's the absolute first thing you do? It's a critical question, right? And the answer? Well, it's not just about the burn itself. It's a universal principle that applies to pretty much every trauma case. And getting it right from second one, it's everything.
Hey everyone, and welcome. Today we're breaking down Chapter 9 of the ATLS manual, Thermal Injuries. For anyone on the trauma team, and especially for surgical assistants, this stuff is foundational. The moves you make in the first few minutes can literally change the entire outcome, so let's get right into the essentials.
All right, here's our game plan. We're going to walk through 5 key areas. We'll start with that initial patient assessment. Then we'll dive into the 3 big burn categories: thermal, chemical, and electrical, because they each have their own unique challenges. And then we'll wrap it all up by tying everything back to the core principles of fluid resuscitation.
Okay, so back to our first question. What's step 1? It's not about treating the burn, it's about seeing the entire patient. You know, in trauma care, we live by the ABCs: airway, breathing, circulation. Well, the E in that framework stands for exposure, and its goal is super simple: find every single injury that could be hiding.
And this initial step has to be thorough. We remove everything: clothing, jewelry, even the dressings that were put on in the field. The logic is simple, right? You can't treat what you can't see. This is exactly how we find those hidden stab wounds or other sources of bleeding. And, log rolling the patient to check their back, that's not optional. It's a mandatory part of the process to make sure we don't miss a thing.
Now let's zoom in on the most common type of burn, a classic thermal burn, the kind caused by heat. The immediate, life-threatening danger here is actually pretty subtle. It's not some dramatic, catastrophic bleed. It's a massive and progressive loss of body fluid.
And this is the point I really want you to take away. Acute burns don't cause major bleeding. Instead, the body just starts leaking huge amounts of fluid right through the damaged skin, and that's what leads to burn shock. The key word here is progressive. It gets worse and worse over time, which is why our response has to be immediate and proactive.
So how do we fight this? Well, we immediately start pumping back in what's lost with isotonic fluids, think lactated ringers, which closely match what the body's made of. If we can't get a standard IV in the arm, we don't waste time. We go straight for an intraosseous, or IO line, right into the bone. We also have to plan ahead for massive swelling, edema. That means using longer IV catheters, they don't pop out, and elevating any limbs with circumferential burns, those are the ones that go all the way around, to help manage that inevitable swelling.
This quote from the manual explains it perfectly. This is why those circumferential burns are a true surgical emergency. The tough, burned skin, we call it eschar, it's like leather. It has zero stretch. So, as we're pushing fluids in and the tissue underneath starts to swell, that rigid eschar acts like a tourniquet, cutting off blood flow and killing the tissue from the inside out.
Okay, next up, chemical burns. With these, the immediate priority is crystal clear, and it's totally different from a thermal burn. Our number one job, our only job at first, is to stop the chemical reaction that is actively destroying tissue.
I want you to think of it this way. As long as that chemical is sitting on the skin, the injury is literally getting worse by the second. Any delay means deeper and deeper tissue destruction. It's that simple.
And the protocol here is so important. If it's a dry chemical, you have to brush off all the visible particles before you add a drop of water, because water can actually activate some of these chemicals and make the burn way worse. Only after you've brushed it all off do you start irrigating with tons of water. And we're not talking about a quick rinse. No, we're talking 30 minutes, maybe even longer, of continuous flushing to stop that reaction in its tracks.
The mantra for chemical burns is simple: time is tissue. Any hesitation, any delay in starting or continuing that irrigation directly leads to more severe, more permanent damage. Period.
All right, let's shift gears to our third category, electrical burns. And let me tell you, these are probably the most deceptive injuries you'll ever see. What you see on the surface, it's almost never the real story. The true danger is hidden deep inside the body. An electrical burn is like an iceberg. What you see on the skin, maybe a tiny entry and exit wound, that's just the tip. Underneath, that current has torn through the body, basically cooking the deep muscle tissue. This hidden damage creates 2 huge threats: compartment syndrome, where swelling in a confined space chokes off blood supply, and rhabdomyolysis, which is just a massive breakdown of muscle.
This quote from the manual: "This is the golden rule for all electrical injuries. You never, ever get reassured by a burn that looks minor on the outside.
You have to assume there is extensive, severe injury happening under the skin until you can prove otherwise.
And on top of the direct tissue damage, there are other huge risks. The sheer force of the shock can cause these violent muscle contractions that lead to falls and even broken bones. We already mentioned compartment syndrome, which needs constant checks. In that rhabdomyolysis, all that broken down muscle releases a protein called myoglobin, which just clogs up the kidneys and can cause acute kidney failure. A classic sign of this? Dark, reddish-brown, almost tea-colored urine.
And when you see that dark, pigmented urine, that's a red flag that changes the entire game. Your standard fluid targets, they go right out the window. The new goal for an adult becomes aggressive, a urine output of 100 milliliters per hour. That high volume is the only way we can flush that dangerous myoglobin out of the kidneys and keep them from shutting down for good.
Okay, so we've covered the three main types of burns. Let's put it all together now and talk about the core principles of resuscitation. Probably the most important idea to really get is that resuscitation isn't a one-and-done calculation. It's a dynamic process where titration is absolutely everything.
This chart really sums up the critical differences. With thermal burns, your main enemy is fluid loss. But with electrical burns, it's deep tissue death and kidney failure. And that's why the approach is so different, right? The initial formulas are just starting points, and the target urine output for an electrical burn can be double or even more than a standard thermal burn. It just goes to show you there is no one-size-fits-all resuscitation.
And this right here is the core principle of modern burn care. Formulas like Parkland, they're just a starting point. They're our best educated guess. But the moment those fluids start running, the formula becomes secondary. The only thing that truly matters is how the patient responds. We are constantly watching their urine output and titrating, adjusting that fluid rate up or down to hit our target. It's a continuous feedback loop of assessing and adjusting.
So that brings us to the final and most important question of all. The initial math is done, the IV bags are hanging, now what? What single piece of data is going to guide every decision you make from here on out? As we've seen, it all comes down to the patient's physiologic response, and the best way we can measure that is their urine output. That one number, that's what turns a simple formula into precise, life-saving care.